Good morning, everyone. Welcome to March 2023 Journal Club. We start with the land acknowledgement. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. We have two exciting presentations this morning. Our first speaker, Dr. Gabriella Jacob, PGY4 Geriatric Medicine resident, special interest in quality improvement, to present on vitamin D and incident dementia. Gabby, please feel free to go ahead.
I'll just share my screen. Can you all see my slides? Great.
It's great, and hear you well.
Okay. So thank you for the kind introduction, Dr. Gendel. Today, I'm going to be speaking on vitamin D supplementation incident dementia. I do not have any conflicts of interest. I decided to choose this after I saw this news headline that caught my eye. Vitamin D prevents dementia. I was intrigued, to say the least, as I was not aware of how vitamin D could theoretically influence cognition, and I decided I wanted to look into this further in case a patient came to me with this trial and I wouldn't know what to say. So my objectives for today are to first talk about some of the proposed mechanisms for vitamin D and cognition, to review some of the prior clinical trials that have been done on vitamin D and dementia, review the current study, and provide a critical analysis. So the pathology in Alzheimer's disease involves amyloid beta plaques and neurofibrillary tangles related to tau. And researchers have studied the regulation of amyloid beta at the blood-brain barrier to try to determine why amyloid plaques may develop. And they proposed that transporters located at the blood-brain barrier that are responsible for moving amyloid beta in and out of the brain may be implicated. So LRP1 is the transporter that moves amyloid out of the brain, whereas RAGE is a transporter that moves amyloid into the brain. And there have been some trials, this one that was done by Guo et al. In 2016, which looked at vitamin D and the influence on these transporters in an in vitro model. And they saw that LRP actually increased, the activity at LRP increased, whereas the activity at RAGE decreased. So they proposed that this could be a way that it could influence amyloid by, encouraging amyloid to move out of the brain while reducing the amount of amyloid that moves into the brain. This did not pan out in their in vivo portion of their research. And this is, again, a very early theoretical model. Other things that have been studied have included the potential neuroprotection from regulation of neurotrophics, decreased glutamate, increased glutathione, and reduction in pro-inflammatory cytokines. But beyond the theoretical, why have researchers looked at vitamin D in dementia? I think this kind of stems from some of these trials that have come out linking vitamin D deficiency and dementia. This meta-analysis published in 2017, which showed a higher risk of dementia in those with serious vitamin D deficiency, which was defined as a level of less than 25 nanomoles per liter, compared to sufficient vitamin D, which was defined as over 50 nanomoles per liter. And this was stated as very low quality evidence, given the observational nature of these trials, the lack of kind of control or adjustment for important confounders like ApoE genotype, and the fact that these studies are prone to reverse causation. So the person may have low vitamin D because of the dementia and not going outside or being exposed to sunlight, rather than as a cause of the dementia. When there's been systematic reviews done on vitamin D. For example, this Cochrane review, which was published in 2018, they looked at vitamins and mineral supplementation in dementia, and they only found 2 randomized controlled trials for vitamin D and dementia. The first was the Rossum trial from 2012, which was in women, and they were treated with vitamin D and calcium supplementation. They were also receiving hormone replacement therapy, and the outcome was a secondary outcome for cognition, with no difference in incidence of dementia or mild cognitive impairment over a follow-up of 7.8 years. There was another trial which was much smaller, with higher dose vitamin D, and only followed people for 6 months without a change seen in MoCA score. More recent randomized controlled trials, like the Do Health trial, which looked at vitamin D, omega-3, and strength training program, looked at 6 primary outcomes, one of which was a MoCA score. And when those who were treated with vitamin D 2,000 units compared to placebo, they did not see any change in cognitive function. And this was over a median of 2.99 years of follow-up. The VITAL trial, which looked at vitamin D and omega-3, that was evaluating cancer and cardiovascular disease in terms of their primary outcomes, also had an ancillary study called the VITAL COG that was published in 2021. And they did not see any change in cognitive function with 2,000 units of vitamin D compared to placebo over 2.8 years of follow-up. So that brings us to our current trial of vitamin D supplementation in incident dementia, the effects of sex, ApoE, and baseline cognitive status. This was published in Alzheimer's and Dementia, Diagnosis, Assessment, and Disease Monitoring, which is a journal that is published by the Alzheimer's Association, and the researchers were based out of Calgary. Their hypothesis was that any exposure to vitamin D would result in a lower incidence of dementia. Their population included dementia-free individuals, which they defined as normal cognition and mild cognitive impairment, that were included in the National Alzheimer's Coordinating Database, which gets data from 40 dementia research centers in the United States. The exposure was vitamin D supplementation as reported on their NAC A4 medication form. And this was compared to no vitamin D supplementation. The outcome was incident dementia diagnosis. Just to make it clear as well, they were accessing this data retrospectively, although they stated as prospective. This data was collected prospectively for the database, but this data was accessed with a data freeze of 2021. So the data they used for the trial was from 2005 to 2021. Their inclusion criteria were dementia-free, which they defined as normal cognition or mild cognitive impairment, at least 1 follow-up visit, and baseline status for all covariates. And they excluded individuals who were missing follow-up visits, who had dementia at baseline, who didn't have the covariates of interest available, or who were exposed to vitamin D during the trial if there was no baseline exposure to vitamin D at the start. Just to note as well, they did not report any baseline or subsequent cognitive testing in the paper in terms of how they define normal cognition or mild cognitive impairment or any functional assessments, but they said that these diagnoses were based on research criteria and that the neuropsychological tests that are used included a MoCA, craft story, digit span, and a Boston naming test. These are the results in their table 1. As you can see, this was quite a large trial with over 12,000 individuals. I will note that there were differences between the vitamin D and no vitamin D groups. The vitamin D group had substantially more women, at 70.5%. They also did have higher education. There were less Black individuals, as well as less individuals with mild cognitive impairment compared to the no vitamin D group. They also had less depression. And so those are important to note as we move forwards. The primary analysis included a Kaplan-Meier survival curves for dementia-free survival over 5 years. This curve here demonstrates the vitamin D and non-vitamin D exposed groups. The incidence or dementia-free survival were significantly different between the two. Here, as you can see, the numbers were 83.6% dementia-free survival in vitamin D exposed, compared to 68.4% in non-vitamin D exposed. But again, these included both normal cognition and mild cognitive impairment. When they then stratified by cognition, the differences between the groups were much smaller. They were still statistically significant. They then conducted a Cox regression analysis looking at the risk of incident dementia over 10 years. And in this model, they controlled for baseline age, sex, education, race, cognitive diagnosis, depression, and ApoE status, and then analyzed the exposure versus non-exposure to vitamin D. And the hazard ratio they came up with was 0.6, meaning a 40% lower incidence of dementia in the vitamin D group. They then individually examined the other variables in the model and not unexpectedly found an increased risk of dementia in those who had mild cognitive impairment, in those who had depression, those who were carriers for ApoE as examples. When they looked at those who did develop dementia, these majority were Alzheimer's dementia diagnoses. 14.6% in the vitamin D exposed group developed dementia compared to 26% in the non-vitamin D exposed. Just will bring up as well that there was a very small proportion who were diagnosed with vascular dementia, but there were more diagnoses of vascular dementia in the non-vitamin D exposed group. They then looked at relative hazard ratios that were associated with vitamin D exposure for each covariate. So they looked at vitamin D exposed women compared to non-vitamin D exposed women, and they found a hazard ratio of 0.51, meaning a 49% lower incidence of dementia. And then when they did the same for men, they found a 26% lower incidence of dementia, which they summarized being the effect of vitamin D was greater in women compared to men. This kind of follows when they looked at normal cognition compared to mild cognitive impairment. There was less effect of vitamin D in mild cognitive impairment, less effect in those who were depressed as well, and also in those who were carriers. They looked at the different formulations of vitamin D that individuals were exposed to, and all the formulations of vitamin D were associated with a reduced incidence of dementia. So that brings us to our critical appraisal. I used the Joanna-Briggs checklist for cohort studies, and I started out looking at the two groups and were they similar and recruited from the same population. So I said no, the two groups were not similar at the start. As I had mentioned, the vitamin D exposed group had significantly more women. They also had more education, less Black individuals, less mild cognitive impairment, and less depression compared to the non-vitamin D exposed. In terms of were they recruited from the same population, for that I said yes, because they did both come from the NAC database, and there were clear inclusion and exclusion criteria outlined at the start. Were the exposures measured similarly to assign people to both exposed and unexposed group? So I said yes. In this case, the exposures were measured based on the NAC medication form for both groups. Was the exposure measured in a valid and reliable way? So I argue no. Participants with baseline exposure to vitamin D supplement were considered the vitamin D exposed group. But those who did not have exposure to vitamin D at the start, but were subsequently exposed, were excluded from the trial. While in contrast, if you were taking vitamin D at the start, but stopped taking it during the trial, you were still considered the vitamin D exposed group. They also didn't record information on exposure history. So if someone was taking vitamin D and stopped taking it right prior to the start of the trial, then they would have been classified as not exposed to vitamin D. They also didn't have any dosing available of vitamin D or any vitamin D levels to really accurately measure the exposure of interest. Were compounding factors identified? So they did include confounders like age, sex, education, race, cognitive status, depression, and ApoE genotype, but they did not evaluate for vascular risk factors, which was interesting, as we know that this is a significant risk factor for development of dementia, and they didn't look at alcohol use or smoking status. So I argued, no, they did not identify all compounding factors that should have been included in my mind. Were strategies to deal with compounding factors stated? So they actually didn't explicitly talk about how they dealt with confounders. They commented that they did, Cox proportional analysis to, take into account age, sex, etc. And the other thing was interesting is they did their Cox proportional analysis and commented on the 40% reduced incidence of dementia in the vitamin D exposed group, but they didn't choose to do a separate analysis with just normal cognition or just MCI to see if this influenced the results. So I said no. Were the groups and participants free of the outcome at the start of the study? So the participants were classified as dementia-free or mild cognitive impairment based on clinical assessments at dementia treatment centers. But I would argue that mild cognitive impairment is a precursor state to dementia with a high rate of conversion to dementia, and therefore should not have been included in the trial. So I argue no. Were the outcomes measured in a valid and reliable way? So the participants did receive follow-up with neuropsychological testing and clinical evaluations. So I said yes, but interestingly, as I noted, there were very low rates of vascular dementia diagnosis. Despite this being, the second most common type that we see in practice, and even mixed dementia was not noted as well. And was the follow-up time reported insufficient to be long enough for the outcomes to occur? For this, I said yes. This was done over 10 years, which could capture the development of dementia. So that is one of the benefits of a longer cohort study. Was follow-up complete? And if not, were reasons for loss to follow-up described and explored? So in this case, no, they didn't have complete follow-up. Those individuals were excluded, and the reasons for the individuals not coming back was not explored. And there were no strategies taken to address the incomplete follow-up. Those individuals were just not included in the trial to start with. So in conclusion, I identified some serious methodological issues in this study. There's no conclusive evidence from this trial for vitamin D in the prevention of dementia, but I will continue to think about vitamin D for other indications as needed for my patients. I'd like to open the floor up to questions, and thank you for your time.
Thank you very much, Gabby. As always, both the visually presented materials and your expression exceptionally clear and articulate. We have a question from Gary. Go ahead.
Gabby, great job. Thanks very much for your presentation. I mean, generally speaking, I tend to view observational studies as hypothesis generating. And I always think, and I guess because I'm older than you, but some of the others participating, the history of what happened with the studies on hormone replacement therapy that were based initially all on observational studies that found all of these benefits, including for cognition and heart disease and various other things. And then when they did that excellent randomized trial, found that most of the things that were found to be beneficial in the observational studies, in fact, were not in the randomized trials. And the interesting thing, similar to here, when you looked at all those hormone replacement therapy observational studies and the baseline characteristics, there are always numerous differences between those who took hormone replacement therapy and those who didn't. And the issue becomes, even if you try to do statistical analyses to correct, the question you have to ask when the populations are so different at baseline, can you really use statistics to create equivalent groups to then come to conclusions that you can rely on. So I think it's always difficult. Plus, there have been numerous randomized trials that have not shown vitamin D to be effective. Most recently, I think Manuel Montero Adasa, they did a Canadian study. He was a huge believer in vitamin D, self-admittedly, and his study found that vitamin D was not effective. So I think you did a great presentation, and I think it's always interesting to, in terms of what do we take away from these observational studies.
Thank you very much for those comments, Michael.
Again, I want to concur with Gary about the excellent presentation. It's funny, I look at this in a somewhat different way. It's interesting to know if vitamin D indeed decreases the risk for dementia. It may or may not in the long run. And in this study that Gabby presented, most of the evidence was positive, even though it wasn't the best run, the best designed, et cetera, study. But I look at it as, in vitamin D in general, in aging, is it worth giving? It's cheap. It's almost free. In some places it is free. And we know, as Gabby said, it has other benefits, predominantly in terms of bone health. So the question is, although this is interesting, and it's good to know if it, because it enhances our ability to convince people that they should take vitamin D if it did decrease the risk of dementia. But on the other hand, should we be using vitamin D anyway because of bone health? And if there's a benefit for dementia, wonderful, just a little cream on the pudding. Thank you.
Thank you, Michael. Any other questions from the audience? Gabby, I might add, one of the confounders that I didn't see, and perhaps I simply overlooked, that may not have been reported, were medications.
They didn't report on medications either, no.
And perhaps a question for both you and Gary, so to speak. Observational studies being hypothesis generating, what about subgroup analysis or ancillary studies of large RCTs when they are not the primary outcome? And so Gabby mentioned the Vital study, which was quite a large RCT of vitamin D for different primary outcomes, but they still had a 3,000 person subgroup that yielded no difference in cognition. Gabby, if I'm reporting that
yes,
accurately.
that's correct. Yeah, it was 3,000. It was still quite large.
And so, you know, I would appreciate any feedback on the weight, because we're unlikely to see another RCT so large with cognition being the primary outcome.
It's a good question, Dov. I mean, generally speaking, I guess one would tend to consider subgroup analyses as hypothesis generating, but there's some elements, I suppose, that you certainly take into account as to maybe how much store you put in them. So, and as you well know, the notion of, were these pre-specified analyses, for example, that's a critical element, because I think certainly you get consensus if they're not pre-specified that there definitely should be considered as purely hypothesis generating. So, you know, there are some elements to the methods that you take into account in terms of how much store you put in them. You know, and then the other element that you're well familiar with is most people don't change practice based on a single randomized trial, regardless, even if it's not a subgroup analysis. So there's a number of considerations that people will take into account. You know, a pre-specified subgroup analysis in a randomized trial, in my mind, would hold considerably more sway than an observational study such as this, and for the reasons that Gabby identified, and the major differences in groups at baseline.
The most glaring example of that I might offer is the Sprint Senior and how influential the Sprint Senior subgroup analysis was, in addition to all the other data, I guess, on hypertension. Any other questions from the audience to Gabby? Again, thank you very much. Exceptional as always. And
Thank
we
you.
will move to our second presentation for this morning. Dr. Peter Hoang, PGY4 Geriatric Medicine resident, and recently accepted to postgraduate training in clinical epidemiology at the University of Toronto, is with us this morning to present on predictors for self-discontinuation of anti-osteoporosis medication. Peter, over to you.
Great. And you can see the presentation slides, okay?
Yes, and hear you very well.
Thank you, Dr. Gendel. So today I'll be presenting this journal article, as mentioned by Dr. Gendel. It was published in PLOS ONE on September 2022. I have no conflicts of interest to disclose. So I've never had the opportunity to taste a bisphosphonate, but in preparing for this presentation, I have found that there are reports that both oral and intravenous etidronate in particular can cause a transient metallic taste. I dare to say this is probably worse than broccoli for a child. While the purpose of this journal club is not to encourage pharmaceutical companies to improve the taste of medications for all ages, I think it's important we understand the reasons that drive non-adherence to medications. As such, I picked this article today to explore those reasons for discontinuation of a treatment strategy we frequently discuss with patients. For our learning objectives, we'll review the physiology of bone health, review the anti-osteoporosis agents, as well as the current evidence and its adherence to therapy, and then we'll go through the critical appraisal of the current study. Bone homeostasis is mainly controlled by the balance between osteoblasts, osteocytes, and osteoclasts. Osteoblasts are derived from mesenchymal stem cells, which are the same cells that form adipocytes, chondrocytes, and myocytes. Osteoclasts come from hematopoietic stem cells, which are of a macrophage lineage. Osteoblasts produce bone, primarily using collagen, whereas osteoclasts dissolve minerals and digest bone matrix with enzymes. Osteocytes are the major cellular component in bone tissue and originate as well from osteoblasts. Both use separate and shared regulation pathways, which we'll discuss shortly. Bone remodeling is a relatively slow process occurring over months. A team of cells called the basic molecular unit moves along the trabecular surface of the bones as shown here. They expose collagen and attract pre-osteoclasts, which fuse into multinucleated cells. These osteoclasts will then break down bone, and as they resorb collagen, will stimulate pre-osteoblasts to proliferate, which aligns at the bottom of the cavity and forms osteoid, which is shown in the blue blocks. The osteoid will eventually mineralize. Then the osteoblasts turn into lining cells and are trapped in the matrix from which they formed and become osteocytes. These terminally differentiated cells have important paracrine and endocrine roles in bone homeostasis. This process helps to both repair microdamage in the skeleton, as well as supply calcium as needed to maintain calcium homeostasis. Bones are regulated by a number of many hormones, as the audience is well aware of, including androgens, estrogens, PTH, growth factors, inflammation, amongst others. The reduction in bone strength and microarchitecture with at least 2.5 standard deviations or more below the mean of a young adult is the definition we use for osteoporosis. This definition also includes fracture occurring in the setting of trauma less than or equal to a fall from standing height, with the exception of certain bones. The effects of osteoporosis at a public health level are profound, both for failure in identifying a first fracture as well as secondary prevention. As this audience is well aware of, many fractures go unidentified, either as silent vertebral fractures or not clinically recognized at the point of contact. This here in the graphs on the right side are data from the European prospective study and shows a rapid increase in osteoporotic fractures with age, particularly notable in the hip and radiographic vertebral fractures. The lifetime probability of a hip fracture in a 50-year-old Caucasian female is 14% and 5% for men. It's about half of that for African Americans and similar for Asians and non-Black Hispanics. 20 to 25% will experience mortality the following year, with 30% experiencing functional decline. Given such effects on morbidity and mortality, treatment to optimize remodeling and prevent future fractures is imperative. At the cellular level, osteoporosis occurs due to that imbalance between osteoclasts and osteoblasts, which I'll briefly undergo the physiology on the treatment strategies. Bisphosphonates use a derivative of inorganic phosphate, which is a byproduct of normal human metabolism. Studies from the 1960s showed that pyrophosphate inhibited calcification by binding to hydroxyapatite, which is the primary component of minerals in bone. This is represented by the fibril structure and the hydroxyapatite crystals in the light blue. The bisphosphonate is the inorganic molecule and prevents binding of osteoclasts, inhibiting its activity and promoting its apoptosis. There is no talk about osteoporosis without pulling this diagram I used extensively from Harrison's Internal Medicine. As the audience will recall, the first diagram on the left, activated fibroblasts, lymphocytes, dendritic cells respond to pro-resorptive factors. This may include vitamin D, PTH, and steroids. These cells will secrete rank ligand, which activates osteoclasts to promote bone resorption. On the other hand, on the right side, anabolic factors such as calcitonin will cause osteoblasts to secrete osteoprotegrin, which blocks bone catabolism and promotes anabolic bone growth. This additionally reduces the survival of osteoclasts. The use of rank L inhibitors, i.e. denosumab, or estrogen receptor modulators, SERMs, reduce resorption, while the use of PTH, i.e. teriparatide, to change the homeostatic variation induces formation, i.e. an anabolic. Finally, we have sclerostin, to which bone homeostasis is also dependent on Wnt, which is the vital cellular process of gene transcription and differentiation. In this case, this pathway helps to differentiate mesenchymal stem cells, which, as you will recall, are precursors to osteoblasts. Sclerostin inhibition promotes osteoblast maturation and survival while inhibiting osteoclast generation. The complete absence of its expression in humans causes exaggerated bone formation, which is known as sclerosteosis. And this is the mechanism that's taken advantage of in romosozumab. This table is taken from the ACP guidelines for pharmacological treatment of primary osteoporosis. It was published in the Annals of Internal Medicine on January 2023. The table on the left shows the studies for hip fractures, whereas on the right, clinical vertebral fractures from 12 to 36 months. The green bars show the number needed to treat per 1,000 patients to reduce further fractures. Overall, there is good evidence for the use of bisphosphonates, denosumab, romosozumab, and teriparatide to reduce hip and clinical vertebral fractures with a range in the certainty of evidence. This slide shows the number needed to treat and certainty of the evidence for hip fractures and clinical vertebral fractures after 36 months. Although the only agents studied are bisphosphonates and denosumab, there's still strong evidence for its use in preventing future fractures. Given the substantial individual and systemic burden of osteoporosis, as well as evidence of treatment benefit, adherence is paramount in the clinical setting. A systematic review by Victoria et al. In 2019 assessed the prevalence of adherence of oral bisphosphonates and looked at two outcomes: persistence and adherence. Persistence is defined as the amount of time someone will at least remain on the medication, whereas adherence is the amount of time they will take the medication at the frequency prescribed. This systematic review found that among 60 studies of persistence, as shown, these values will drop dramatically over 3 years. Similarly, for adherence of 55 studies over 2 years, as low as a quarter of patients were still taking their bisphosphonates as scheduled. A study by Yu et al. In 2019 used retrospective cohort data from 2001 to 2010 of 13,000 persons with a hip fracture. They followed mortality based on adherence of anti-osteoporosis medication. Most patients were on alendronate followed by raloxifene. Adherence was calculated by the medication possession ratio, or MPR. This is one method that's used to measure adherence and is calculated by the total day supply of the medication divided by the number of days in the period. It's effectively the same way when we all go to Connecting Ontario and calculate the number of prescriptions and number of remaining medications we expect a patient to have. As shown in this Kaplan-Meier curve, over 5 years of follow-up, those who had greater than 80% adherence had reduced all-cause mortality. As such, one can easily conceptualize that optimization of adherence and persistence rates are necessary. With that in mind, we head towards the purpose of the study, which was twofold. Number one, what are the reasons for discontinuation of anti-osteoporosis medications? And number two, What are the risk factors for self-discontinuation in those who have stopped taking their medications? The study used retrospective data from the osteoporosis database at Taichung Veterans General Hospital in Taiwan from 2016 to 2018. Individuals were identified based on the presence of osteoporosis, osteoporotic fractures, and had discontinued their medications. For fractures, they report including vertebral, hip, humeral, and radial ulnar fractures. All traumatic accidents were excluded. All enrolled participants were divided based on the type of anti-osteoporosis agent. This included bisphosphonate, SERMs, teriparatide, and RANK-L inhibitors. Furosemide inhibitors were not reported in this study, and to my understanding, would not have been made available until 2019. Data were collected for patients who discontinued their medications between 2016 and 2018, who were then able to be interviewed by telephone to determine their reasons for discontinuation. The discontinuation criteria, as shown in this slide, are as follows: denosumab 6 months plus 8 weeks since the last dose, teriparatide 8 weeks since the last dose without any other agent, bisphosphonate or SERM 12 months since the last fill. For those who received multiple agents, the last type of medication they received prior to discontinuation was recorded. Available BMD measurements of the femoral neck and lumbar spine were obtained, though I'm unclear when the BMD was obtained relative to the start or discontinuation of the study. It's also unclear if any repeat BMDs were obtained. The types of osteoporotic fractures are included listed in this slide, which include vertebral, hip or pelvic, humerus or radius, ribs, tibula fibula, or patella. Those with high impact trauma, pathological fractures, or patch disease were excluded. The primary outcome were the reasons for discontinuation. These were stratified into 3 groups: self-discontinuation by the patient, physician recommendation for a drug holiday, unintended discontinuation due to mortality, but were otherwise taking their medication up till the time of death. Self-discontinuation reasons were further explored on telephone for the patients, that were included in this study. 3 tests were performed on the data that were collected. Demographic data were reported as medians, and so presumably the data was non-parametric. A Kruskal-Wallis test was performed to compare the collected patient variables with the type of anti-osteoporotic agent. It was also used to compare the reasons for discontinuation based on the 3 stratified groups. The Kruskal-Wallis test is an ANOVA equivalent in a non-parametric form. Logistic regression was also used to identify factors which were associated with self-discontinuation, stratified by the agent that was used. Finally, post hoc analysis was calculated using the Bonferroni correction. I always find these journal club preparations an opportunity to learn more about some sort of statistical method. So as this audience is well aware of, type 1 error or false positive is typically set at a threshold of 0.05. However, when multiple tests are being done on the same sample, the risk of false positive increases. It's similar to the old adage, if there's a will, there's a way. If I do enough t-tests, eventually one will be positive. The family-wise error rate is the probability of at least one false positive when multiple comparisons are being done. 2 common tests are Bonferroni and Tukey, honestly significance tests. I highlight the equation on the right side of the Bonferroni correction, which is, for me, straightforward to understand, where you set the alpha above at 0.05, and you divide that by the number of tests that you do. As you increase this number of tests, the threshold required to have a significant p-values continues to decrease. Another important piece I learned is that it's not always necessary to control for type 1 error. When studies define their primary outcome and the remaining outcomes are exploratory or secondary, that's one situation it may not be necessary. Another situation is what you consider a family of measures. For example, in this study, with someone who has osteoporotic fractures, the type of fracture, their sex, and their type of agent are all similar enough to be considered a family. These may not always be the case, and it's sometimes up to the reader to decide of its importance. With that in mind, we head towards the results of the study. 1,195 participants were included for those who had discontinued, with close to half lost for reasons as shown in this diagram, which includes loss to follow-up at other hospitals, and could not communicate with the person via telephone. Of the 694 participants who were included for analysis, 374 discontinued of their own accord, 64 discontinued as per physician suggestion, and 256 had an unintended reason for discontinuation, which as listed was mortality. The reasons for self-discontinuation are listed below, to which it was driven primarily by missed appointments and drug factors. Unfortunately, drug factors are not further described. I also note that cost was a barrier here for reasons for self-discontinuation. The average participant was female, age 75, with a BMI of 23, primarily using denosumab, followed by bisphosphonate and SERM. They were on calcium supplementation, but generally not on vitamin D. Many had osteoarthritis, followed by hypertension and diabetes. I would now like to highlight some of the differences apparent based on the type of anti-osteoporotic agent. I will first describe the findings claimed by the authors and welcome any discussion at the end. Those who discontinued teriparatide were more likely to have hip fractures, have lower BMD, including of the lumbar spine and femoral neck, compared to other agents used. Those are highlighted in the p-values in red. It's also important to note that teriparatide and zoledronic acid had rather small sample sizes compared to the other agents. This slide is a continuation of table 1. Notably, age, weight, BMI, the presence of alcohol consumption, and comorbidities, the ones that are measured, are not different. Females are significantly different for raloxifene compared to bisphosphonate or denosumab. Teriparatide was also different for females compared to bisphosphonate or denosumab. I found this conceptually quite reasonable, given that SERMs are most likely to be prescribed to females, and older females are at the greatest likelihood of having high-risk features requiring teriparatide. Vitamin D supplementation was also different and most frequently adherent in the denosumab group. Finally, there was also a difference in smoking that was lowest in raloxifene and teriparatide groups. I highlight here the second table, which describes the reason for discontinuation based on the participant demographics and variables measured. The three groups are self-discontinuation, physician suggestion, and unintended discontinuation. These are listed as S, D, and U, respectively, and their p-values for pairwise comparisons with Bonferroni corrections are shown on the right-hand side of the table. Female gender, fracture sites other than the hip, and the use of raloxifene were correlated with a higher likelihood of self-discontinuation compared to other groups. I had a different interpretation than the authors and welcome any thoughts about my interpretation of these findings. I understand that pairwise comparisons are used to show differences amongst the groups. So for example, as shown in red, for female and spine fractures, these are different between self and unintended discontinuation. However, it's also different for recommendation by physician and unintended discontinuation. I next like to highlight the percentages that are shown as the important pieces in green. As you can see here, these numbers for self-discontinuation and physician recommendation are rather similar, with the difference being an unintended primarily. Similarly, the self-discontinuation with these percentages, the one that's quite offshoot are discontinuation by physician and unintended discontinuation. To summarize, the way I have interpreted these is that there's a difference between these three reasons for discontinuation, but not necessarily within self-discontinuation alone. In other words, unintended discontinuation participants were less likely to be female and more likely to have a spine fracture. The following is a continuation of Table 2 using pairwise comparisons of the data. These show the use of anti-osteoporotic medications prior to discontinuation with the agent as the exposure. While a claim is made that raloxifene is significant in self-discontinuation, these pairwise comparisons are not done on the right-hand side. It's also very important to note that there's only a small sample, again, of 7 in the physician suggestion. And there's a single p-value which shows that some difference exists between these three groups. Based on these percentages, we can see that self-discontinuation is likely different from discontinuation by physician suggestion, but not very different from unintended, with both in the 20% range of the groups that discontinued. It probably does not change the conclusion that raloxifene is more likely to be self-discontinuation, however, may not be different from unintended. It also may be driven by the small sample size of physician suggestion. Univariate and multivariate logistic regression were completed to determine the predictors for self-discontinuation. Amongst that, older age, male gender, calcium supplementation, and the use of teriparatide were associated with reduced risk of self-discontinuation. As shown on this slide, older age had an odds ratio of 0.95, male gender an odds ratio of 0.48, teriparatide 0.19, and calcium supplementation 0.67. Some of these confidence intervals, notably age and calcium, are rather close to 1. When stratified by anti-resorptive and teriparatide, male gender was less associated with discontinuation for anti-resorptive. Those who had a hip fracture on teriparatide were less likely to discontinue. It's unfortunately unclear to me what the rationale was to combine all the types of anti-resorptives, so denosumab, bisphosphonate, and SERM, when they have different frequencies. A secondary part of this study was also to use telephone interview and health education, to which a surprising 22% resumed their anti-osteoporosis medications upon and had follow-up. The type of health education is not specified. To put this data into perspective, I highlight a Cochrane review of health interventions to improve medication adherence that was published in 2014. 50 RCTs were included in this study with over 14,000 participants. Interventions range from behavioral, mixed to education only. And for a meta-analysis using a threshold of adhering at least 80% of the time, there's low and very low quality evidence for its improvement on adherence. This is notably different from the outcome that's measured in this study, which was just to have someone follow up again and resume their medication, but at least should be placed in this perspective in the limitation of health education alone. I use components of the Joanna-Briggs critical appraisal for the study. Question 1, were the study subjects and setting described in detail? I gave this a question mark. To summarize, patients came from a retrospective data set to which of those who had osteoporosis, fractures, and had discontinued their medications who were then able to be telephone interviewed. We don't know what some important criteria I thought might be necessary were whether they were community dwelling, which is assumed, when their fracture was, or the time of discontinuation. Question 2, was the exposure measured in a valid and reliable way? The main exposure variable in the setting I thought was the type of anti-osteoporotic medication. As you will recall, the criteria were defined for each of the anti-resorptives as well as teriparatide. I found it somewhat odd that the definition of discontinuation was 12 months since the last claim for bisphosphonate and raloxifene, but this may be based on prescribing schedules in Taiwan, which may not be the usual typical 90-day windows as done in Canada. Outside of prescribing cultures, however, I did not think the criteria should have been overarching on bisphosphonate if you were on zoledronic acid. Question 3. Were objective standard criteria used for measurement of the condition? I thought the measurement methods were appropriate with the standard definition of osteoporosis as well as its fractures. The conditions for discontinuation, so self, physician suggestion, and unintended, were also reasonable. Further stratification of the drug factor reasons would have been helpful for clinicians to understand reasons for discontinuation, particularly as the study was looking for risk factors associated with that. Question 4, were confounding factors identified? There is a selection bias in those who are uncontactable, which in my opinion would be of the group of most interest and potentially most vulnerable to low adherence and persistence. In line with this, the reasons for discontinuation came from telephone interviews, which suffers from recall bias. I think these are appreciated as limitations of the study. Some other important confounding factors that may affect the study include the type of anti-resorptive and its frequency, its method of administration, the level of health literacy, and the presence of cognitive impairment. For this reason, I gave it a question mark. Question 5, were strategies used to deal with confounding factors stated? Unfortunately, no method was used to reduce the bias that occurred in the study. They could have potentially searched for data from other databases as one potential method to mitigate confounding factors. Question 6, was appropriate statistical analysis used? I think that overall the types of statistical analysis were appropriate. A further description of the variable used in their modeling for regression would have been helpful for a reader. Given the absence of reporting, I gave this a question mark. The Bonferroni correction as well, which does reduce false positives, is the most conservative type of test and could increase the risk of false negative. I'm not sure why this method was selected, as I'm not an expert in this area, as other non-parametric methods, to my understanding, can be considered, but I defer this to the expertise of statisticians. As this audience is well aware of, there are many difficulties in studying this population with many different contributing and confounding factors, which I think deserves to be highlighted as considerations in the interpretation of the study. As you'll recall, these are the patient and environmental factors. For the patient factors, that includes health literacy, income level, cognitive impairment, presence of potential adverse drug events, which are unmeasured, and the mortality data. For environmental factors or other, that would be the anti-resorptive by frequency or administration method and the living situation. The summary I've taken away from this article is that a large number of patients will self-discontinue their medications. The study found that 50% discontinued on their own, driven primarily by missed appointments, following by drug factors. Whether these drug factors were polypharmacy, side effects, interactions, adverse events is unknown. It would have been interesting if the agents were grouped by administration method to see if there was a difference. I don't think strong conclusions can be drawn based on the results of the study alone on factors associated with self-discontinuation. What we do know is that BMI, the presence of alcohol consumption, and the type of medication other than teriparatide are not predictors. Many confidence intervals are rather close to 1 as well. Finally, some sort of unspecified health intervention or education can improve adherence. For my bottom line, given these limitations, several factors may be associated with greater risk of self-discontinuation, and physicians can continue to play an important role to improve a patient's health literacy to prevent inappropriate discontinuation. I thank everyone for being present today and welcome any questions.
Thank you very much, Peter. Quite an exceptional and powerful presentation. I really enjoyed the hook and the detailed description of the statistical method, as well as your summary and bottom line. Michael has his hand up, so we'll go over to Michael for the first question.
Yeah, Peter, that was, I think, not only a very good presentation in terms of its format and discussion, but I think an important article. I mean, all of us in practice know this happens not just with these drugs, with other drugs. And I mean, the simple thing is, yes, the drugs are good, give or take a little, they work well in most people, they're usually tolerated, although if they're not, we usually have alternatives. So the real question is, what are the strategies to enhance people's adherence? And there's a lot of studies on adherence. And I think one of the problems is leaving it to the physician is a resource. You cannot have people coming back to the physician for them to say, remember, remember, remember. But I know the osteoporosis clinics that I know usually have someone else besides a physician, whether it's a nurse practitioner, clinical nurse, somebody who in an ongoing way can encourage, because it's not just education. From my experience in clinical medicine, it's encouragement. It's explaining why this is good for you and your family and everybody else. And now with the digital world, if telephone doesn't always work, I can tell you, but a lot of people now are doing Zoom. I'm amazed. And I think if possible, a face-to-face encouragement by somebody who the person trusts should be looked at as a way of enhancing adherence. Thank you very much.
Thank you, Michael. We open it up to the audience for further questions. There's some comments in the chat box. Marjorie Hammond, well done, Peter. Agree, and Minnie states, people living with dementia and not having support for adherence of medications may not be able to be adherent to the meds. Do they take these individuals into account?
I echo those same sentiments. To my understanding of this article, I don't think measurements of cognitive impairment or even cognitive scores were incorporated. So it certainly could have been a risk factor for those discontinuing for any number of reasons.
Thank you, and thank you, Minnie, from one of our hybrid sites. Thank you for joining on the comment. Perhaps, Peter, I can also, a statement, share your frustration that the drug factors weren't elaborated in further detail, but you also did mention that, you know, drug class was not predictive other than teriparatide. And so perhaps I'm trying to grapple with those two ideas, that further drug ideas, but drug class was not predictive. And so how does that reconcile?
Yeah, I wondered the same when looking at their study. I wish they kind of did their based on osteoporotic agent. Like I don't know if there might have necessarily been a difference, even if they included the type of class or the administration method or its frequency. However, I think the difference that underlies this should be taken into like the fact that the teriparatide group is so small. I tried to see if other data for the amount of teriparatide use in other studies, but didn't come across it or didn't look deeply enough, to be honest.
Because I know I often, when I write the prescription, or if I write the prescription or suggest, you know, what is the best way, the once a day, once a week, once a month, you know, twice yearly, and those adherence factors or drug factors may influence my choice. But perhaps this paper doesn't shed light on that.
Great presentation, Peter. If I could just add to what's already been stated, you know, thanks for presenting a paper that relates to adherence, because I think it's something, frankly, that we as physicians probably don't spend as much time on as maybe we should. And there's so many things we need to keep in mind. But along those lines, I think particularly as geriatricians, we look to team approaches. And, you know, with respect to adherence in particular, I often wondered whether pharmacists could play a much more active role than they do, given that they're the ones that fill prescriptions and have information about, you know, the number of days supplied and things like that, whether there should be greater effort, you know, with increasing roles of pharmacists in various things, whether this is an area that we should focus more deliberately on in terms of the role of the pharmacist.
Yeah, I think so too. When I was reviewing the studies that were included in that large meta-analysis or the large Cochrane review, the behavioral modifications, which did have the greatest improvements in adherence, were generally done by allied health professionals, which included pharmacists and nursing. And I think we should incorporate their roles as allied health professionals in this team model.
Thank you for those comments. Last comment to Jill in the chat box mentions just the comment, denosumab is challenging when patients are homebound, have difficulty making it to the doctor's office or tracking a 6-month drug interval. I've seen this as a big limitation in adherence and factor this in when choosing agents. More support for providing this through home care would be helpful. Varying success with HCCSS nursing administration. Thank you, Jill. That brings us exactly to the top of the hour. I want to thank our two presenters for really just absolutely exceptional presentations, both in the articulation and the visually presented material. Congratulations. By way of announcements, please do complete your evaluations that were sent a few moments ago. We congratulate the PGY5s who wrote their Royal College exams earlier this week, and we look forward to seeing everybody at CGS April 13th to the 15th in Vancouver for those who are attending. So thank you again, Peter and Gabby and everyone for signing in and attending.